You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from the Heart.org Medscape Cardiology, and this is This Week in Cardiology for August 9th, 2024. This week, clinical prediction models versus clinical judgment, CCTA quantification of atherosclerosis, combining AF ablation and appendage occlusion, atrial shunt devices for heart failure, and heart failure optimal medical therapy. Let's start with clinical prediction models versus clinical judgment. Last week on the podcast, I discussed the AHA's new PREVENT equation for predicting future cardiac events based on clinical factors. PREVENT is derived from larger and more contemporary data sets, and experts write that it is better than the old standby pooled cohort equation. The study I discussed compared the PREVENT and PCE and found that PREVENT assigned lower future risks to patients. I also have a column up on the Heart.org website about this that just came up yesterday. I won't rehash the details of the study, but this week I want to highlight the point that PREVENT and the pooled cohort equation are prediction or prognostic models. The CHA2DS2-VASc score is a prediction model, so is the heart score, which often makes me laugh. As an aside, here's why the heart score sometimes makes me laugh. In our defibrillator clinic, we take care of some seriously sick patients who have nearly every possible cardiac and non-cardiac disease you can have and still be alive. And I've received calls from emergency docs telling me about such a patient with an ICD is in their emergency department, and on more than one occasion, the doctor tells me about this patient's heart score. Now, before they get out to answer, and before I knew about the heart score, my brain thought, I don't know the criteria for the heart score, but the patient he is talking about must have a heart score of infinity. Anyways, for these types of patients, these scores are useless and clinical judgment is required. The question I have had, and perhaps you have had too, is how the two methods of prediction compare. A McMaster University-led group published an interesting systematic review comparing empirically the prognostic clinical prediction models versus clinical judgment. The Journal of the Clinical Epidemiology published the study this winter. I saw it from the feed of senior author Professor Gordon Guyette. The first author of this paper is Luis Colunga-Lozano. I love this study question. The challenge of this endeavor is that only observational studies have compared the two prediction approaches. The authors found 41 studies that reported direct statistical comparison between prognostic clinical prediction models, CPMs, and clinical judgment. Some of these CPMs will sound familiar: CHA2DS2-VASc, Has-Bled, Apache, San Francisco Syncope Rule, and Palliative Prognostic Score, to name just a few. Now, the first thing to say is that the authors did a risk of bias assessment, and the risk was high in 39 of the 41 studies they included. By the way, this is the proper way to do systematic reviews and meta-analysis. Lack of detail regarding the statistical analysis and less than 100 events were the most common limitations in these included studies. So the overall results, the clinical prediction models had an overall C-statistic of 0.73. Now remember, coin toss is 0.5. Clinical judgment had a median C-statistic of 0.71, so essentially no difference. Now recall that the C-statistic sums how well a model can distinguish between subjects who experience an event and those who do not. Now, of the 41 studies, 29 studies provided 124 separate discrimination metrics that could be used to compare CPMs and clinical judgment. Among these 124 metrics, 47% found no significant differences between using a prediction model and using judgment. 25% of them favored the clinical prediction model, and 28% favored clinical judgment, and the authors concluded that, quote, in many instances, clinical judgment frequently demonstrates comparable or superior discrimination compared to prognostic clinical prediction models, although models outperform judgment on calibration. Studies comparing performance of prognostic clinical prediction models and clinical judgment require large improvements in reporting. Okay, my comments. On the matter of clinical judgment, let me say that I have seen many patients of mine in the emergency department, often with chest pain associated with AFib. They often have nonspecific ECGs. Recently, I've tried the AI Queen of Hearts clinical prediction model, and it almost always outputs that the ECG is not consistent with occlusive MI. I'm like, I already knew that. High sensitivity troponins in these patients can be nonspecifically elevated due to AF. Heart scores often suggest moderate risk. These situations force you to rely on clinical judgment. In this case, one of the best exam findings, I think, is general appearance. I have activated cath labs on the basis of patients not looking well. A cath lab doc sometimes calls me up and says, John, this ECG is not consistent with a STEMI. But I can tell you about such cases, and I'm sure you can too, that showed severe subtotal occlusions or MIs in progress, despite the fact that the clinical prediction model fails. Clinical prediction models do not capture things like general appearance. And this is what makes me excited to tell you about these findings, that the C statistics were similar, both quite poor actually. About half the time, there were no differences between using a model and using clinical judgment. Sometimes the model was better, sometimes the clinical judgment was better. In the discussion, the McMaster's team underscores that their findings were limited due to the risk of bias in the included studies, which also evaluated widely disparate clinical situations. And they were definitely cautious regarding the use of clinical prediction models. Some of their syntax was downright negative. Quote, thus, our results emphasize the satisfactory discriminative performance of statistical models is insufficient to justify their widespread introduction into clinical practice. Wow. Though the ability to empirically compare these methods is limited by the risk of bias in the included studies, the variability of the clinical prediction models, and the variability of the conditions studied, the overall results don't look too bad for good old clinical judgment. I guess my question for the machine learning and AI experts in the audience is whether these advanced methods will lead to clinical prediction models that are clearly better than clinical judgment. My feeling about this machine learning and AI era is that it's a bit like when the internet came to be. When all we had was AOL and listservs, it was hard to imagine where we would be now with the internet. So maybe clinical prediction models will improve. Right now, though, clinical judgment is highly useful. All right, next topic is similar. This is CCTA quantification of atherosclerosis. Speaking of prediction, the ischemia trial authors have published a post-hoc observational study on the degree of atherosclerosis as measured on CCTA and future cardiac events. The sub-study is in the European Heart Journal. First author, Nick Nurmohamed, sorry about the mispronunciation. The authors used CTA images from 3,711 patients in the ischemia trial. Their goal was to determine the prognostic value of CCTA-derived atherosclerotic plaque analysis in the trial. Now, briefly, recall that ischemia studied patients with stable CAD who had moderate to severe inducible ischemia on stress testing. One group got an early invasive approach, and the other group got medical therapy and angiography only for recurrent symptoms. The overall results were similar to the COURAGE trial and Berry 2D trial in that early angiography, more PCI, did not reduce the primary endpoint of CV death, MI, unstable angina, heart failure, or resuscitated cardiac arrest. And for me, Figure 6 in the New England Journal of Medicine supplement was most instructive. It showed that the conservative strategy led to similar results despite the fact that less than 30% of patients had an angiogram done. Now pause there and think about this. These were patients with chest pain and positive stress test and no cath in 70% of the patients, and the same results at the end of a few years. Now, one key feature in translating ischemia to the clinic is that most patients in the trial had a CCTA done for two reasons. One was to exclude left main coronary disease, and the other to exclude those patients without CAD. I highlight this substudy because A, CCTA is hot, B, despite the piles of evidence supporting the idea that CAD, even severe CAD, is very stable, the clogged pipe frame of CAD persists, and doctors and patients alike remain fearful of severe CAD. Positive stress tests are still hotlines to angiography in many geographies. There is also a lot of talk about how CCTA can not only identify all sorts of plaque, but it also can quantify the burden of atherosclerosis and possibly signal high-risk phenotypes. The same authors previously showed that a greater extent and severity of CAD were associated with increased risk of all-cause mortality in MI. However, invasive management did not lower all-cause mortality at 4 years in any ischemia or CAD subgroup. The goal of this substudy was to quantify the incremental clinical value of coronary plaque quantification. In other words, did CCTA-derived plaque characteristics associate with MI or CV death or the MACE primary in the ischemia trial? And before I tell you the results, let's set out that I am an outside observer in the imaging world. I feel like a neutral judge. The authors did CCTA interpretation of study with an FDA-cleared software service, AI-QCT, which I've never heard of. Quote, the software performs semi-automated analysis of CCTA using a series of validated convolutional neural network models. I know, that sounds a lot more complicated than I'm used to. The authors first showed that the number of vessels with obstructive stenosis, total plaque volume, low-density non-calcified plaque volume, high-risk plaque, proximal non-calcified plaque volume, positive remodeling, and plaque diffusiveness were each associated with the primary outcome of cardiovascular death or MI, and of all those characteristics, variables, the one most strongly associated with the MACE endpoint was total plaque volume. That doesn't seem surprising to me. Now, here's the meat of it. Imagine three different prediction models. One has just clinical characteristics. Model 2 has the clinical characteristics plus the number of diseased vessels. And the third model has the clinical characteristics plus the number of diseased vessels plus atherosclerosis quantification. Again, before I tell you the results, if you believed in AI quantification, you'd expect the third model to be superior at prediction. And the addition of the AI QCT plaque quantification and characterization compared to baseline risk factors improved the model's predictive value for the primary outcome at 6 months, at 2 years, and at 4 years, but there are caveats, so stay tuned. The authors concluded that, quote, enhanced assessment of atherosclerotic burden using an AI QCT-derived measures of plaque volume and composition modestly improved event prediction. Okay, comments. Based on the statistics, meaning the significant p-values, the authors did make a fair conclusion. But I don't think the statistical significance in this case has any clinical significance. To understand the results, I ask you to picture a receiver operating characteristics image. On the x-axis is 1 minus the specificity, and on the y-axis is sensitivity. The three lines, Model 1, which is clinical characteristics alone, Model 2, clinical characteristics plus number of diseased vessels, and Model 3, clinical characteristics plus diseased vessels plus the AI QCT, and the lines are essentially superimposed. The C statistics with the AI quantification increases the C statistic from like 0.64 to 0.69. These are all less than 0.7. Recall that 0.5 is a coin toss, 1.0 is perfect. The degree of improvement from, say, going from 0.64 to 0.9 has no significance at the bedside. Now, the authors appropriately hedged. They used the modifier, quote, modest to modify risk prediction. But I would have used clinically insignificant rather than modest. The two concluding thoughts that pop into my mind here are A, Technology can do a lot, but adding incremental value to basic clinical characteristics is hard. It's almost exactly like the CAC issue that I have with screening. I mean, you get a 10-year risk from the pooled cohort equation or the prevent equation, which are super simple. Now, doing CAC may change that some. It's enough to garner a positive p-value, but its meaning to the average factory worker or farmer or even practicing clinician is near nil. The other thought is this not another indicator about how stable severe coronary disease? Despite positive stress tests, severe disease, CCTA-derived quantifiable plaque, there is hardly any extra signal of events over and above simple clinical characteristics. It's remarkably and profoundly reassuring how simple observation stacks up to convolutional neural network models. All right, next topic is combined AF ablation and appendage occlusion. I received this week an email from Heart Rhythm Society saying that CMS, our payers, has made a new DRG for combined AF ablation and left atrial appendage occlusion. And in the proposed rule, CMS noted that, quote, cases reporting concomitant left atrial appendage closure and cardiac ablation procedures have higher average cost and slightly longer lengths of stay compared to other cases in their assigned DRG. So this new DRG creates higher payments for hospitals, the technical fees, but doctor payment remains the same and under the same rule. Now, this rule states that when a doctor does 2 procedures in the same day, the highest valued procedure is paid at 100% and the second is paid at 50% of the fee schedule. Let me quote you what the HRS email writer wrote. It was in bolded font, quote, "This is a win for HRS as we advocate for access to EP services for those appropriate patients who need to undergo these procedures concurrently." So my comments, my gosh, what the heck is happening to our profession? I mean, no matter how you feel about appendage occlusion, using the verb need and appendage occlusion in the same sentence is ridiculous. We need food and water, but left atrial appendage occlusion? Come on. Now, you all know the story on left atrial appendage occlusion. We've done hundreds of thousands of these procedures, and we have no RCT level evidence that they benefit people. PREVAIL, the seminal FDA regulatory trial, missed its co-primary endpoint of stroke, systemic embolism, and CV death against warfarin. Warfarin. Most of the appendage occlusions are done in patients who are not eligible for these trials like PROTECT and PREVAIL. So we have no compelling data on these patients who were excluded. That we have accepted this procedure as a routine is a blemish on the profession. Keep in mind that AF ablation also does not stand on the strongest evidence base either. I mean, Cabana was a non-significant trial. EAST-AF was not an ablation trial. The heart failure and AF ablation trials were highly selected patients. And please don't cite me quality of life data in AF ablation trials when one group gets a big procedure and the other group gets tablets. But now we can combine 2 procedures in one, and the hospital gets more cash. When left atrial appendage occlusion was done as a standalone procedure, I worried about the robustness of informed consent. But now, when done together, I worry even more about the consent process for this procedure. Then there is the matter of efficacy and safety. I thought maybe I had missed the RCT of combined procedures. No, I guess I didn't miss anything. The UK Liverpool group, led by my friend Dr. Dheeraj Gupta, first author Mark Mills, have a very nice review in Trends in Cardiovascular Medicine on the combined procedure, and I'll link to it. The evidence stems from observational or single-center studies, and it's very weak for combined procedures. One of the concerns that I have regards the safety in that when thermal energy is used, at least, there may be edema of the left atrial ridge, and this may affect peri-device leaks. And I should say that nothing bad has happened yet. This doesn't go into effect until the fall, so I should hold my angst until after the ruling. But I worry, though, that this ruling will further increase the number of both procedures and without any requirement or incentive to study in RCTs. I'd be much happier if the ruling stated that we will change the DRG and we will pay you more for these combined procedures if patients who have them are randomized in a trial. All right, the next 2 topics are fairly short. First one is atrial shunt devices. Jack has published the 2-year results of the sham-controlled reduced LAAO-HF2 trial of the Corvia atrial shunt device for patients with heart failure. Now, briefly, the idea is to put a shunt in the interatrial septum to relieve left atrial pressure in these patients with heart failure. The Lancet had published the primary results of the trial in 2022. This was a 1-year follow-up, and it was non-significant. The win ratio of a long list of outcomes came out at 1.0. Now, to the company and author's credit, they followed the patients for 2 years. The 2-year study also showed no significant difference in the hierarchical composite of CV death, stroke, total heart failure events, and change in health. The win ratio here was 1.01. However, there were divergent ways to look at this non-significant result. One way was to be positive, to break up the results into responders and non-responders. About half of randomized patients who had neither latent pulmonary vascular disease nor a cardiac rhythm management device appeared to respond favorably to the shunt. The authors called these the responders. In this analysis, the responder subgroup appeared to do a little better with the shunt. The win ratio in that responder subgroup sneaked by the significance level with a p-value of 0.04 based on lower rates of heart failure events. Now, that subgroup finding made the conclusion in the Jack paper. Yet there was another finding that did not make the abstract conclusion, and this was that major adverse cardiac events were more common in the shunt arm. It was a big difference, too, 6.9 versus 2.7%. And go look at Table 2 of the paper. Table 2 shows that there were 5 versus 1 strokes in the shunt versus sham arm, 13 versus 7 CV deaths in the shunt versus sham arm, and more patients in the shunt arm had a rise in RV volume. To me, these seem like worrisome signals. The company is not giving up. The device is currently being evaluated further in the Responder HF trial, and they call this a precision medicine trial to determine the efficiency in patients with HFpEF and heart failure with mildly reduced ejection fraction. They will include the subgroup of patients without lower PVR during exercise and without a CRM device. Now, I don't know about you all, but I'm skeptical. In April, I told you about another non-significant atrial shunt trial with a different device. This was called the Ventura V-Wave Interatrial Shunt, and it also failed to meet its primary endpoint in a sham-controlled trial. I don't think this strategy will work, and I worry that peer reviewers and editors did not force the editors to highlight this signal of harm in this 2-year paper. All right, last topic today is optimal heart failure therapy. Jack Heart Failure has published an observational study on outcomes in patients with HFrEF based on their medical therapy. The first author is Vishal Rao. Okay, as background, the first thing to know is that a group of heart failure experts have previously declared what is suboptimal, acceptable, and optimal degrees of heart failure therapy based on the number and doses of the 4 classes of drugs. Now, they used a multi-center registry called CHAMP-HF, and the basic findings of this observational paper were that participants with optimal treatment were younger, had higher annual household income, and were enrolled from practices with dedicated heart failure clinics. Then participants with acceptable or suboptimal treatment. And participants with optimal treatment had lower all-cause death and cardiovascular death than those with suboptimal treatment. The authors conclude that optimal medical therapy scores associate with CV death and all-cause death. Proponents use studies like this to encourage us to push hard on optimal therapy for heart failure. And I think pushing hard can be fine in selected cases. But, as Dr. Mangione writes in the editorial, it depends on the patient. He notes that patients in CHAMP-HF were generally young, mostly male, and had low comorbidity burden. And I would like to push, like Dr. Mangione, back on this movement for aggression in heart failure management. First, let's just use an analysis of this study. The authors tell us first that healthier patients are more likely to get optimal medical therapy. So when they then tell us that patients with optimal medical therapy have lower rates of death and CV death, it becomes obvious to me that this occurs because of their overall health as much as any medical therapy. And there is a finding in the paper that I think confirms this selection bias. Go look at Figure 3. The authors show hazard ratios for death, CV death, and heart failure hospitalizations for the optimal versus acceptable OMT groups. Optimal patients had lower rates of death and CV death, but they had no difference in heart failure hospitalizations. And that's weird, isn't it? Because if you are positing that optimal medical therapy is driving the lower rates of CV death and death, then it should be through a reduction in heart failure events. I think the reason that CV death and death are lower and not heart failure hospitalizations is that healthier patients are more likely to achieve and tolerate optimal medical therapy. And I really think this movement to be so aggressive with medical therapy has problems. I understand that trials have shown incremental benefit of each of the medical additions, but trials are different from real life in the community. If I were in charge of heart failure messaging, I would push a humbler approach. I like the idea of explaining optimal medical therapy using the frame as this is like a maintenance chemotherapy. But I would also say, A, be careful with inpatients. Afterload reduction and MRAs and SGLT inhibitors are okay, but the beta blocker trials were done on stable, ambulatory heart failure patients. And I would say the data on ARNI versus ACE or ARBs is held up by one trial, only one trial, Paradigm HF, which has limitations that I've discussed previously. So I would say use a RAS inhibitor most likely to be tolerated and complied with. So many times I see medical therapy slowed because of hypotension from aggressive use of ARNIs when a low dose of an ACE inhibitor would be a better start. I would say be careful in older patients or those with comorbidities. These patients were not included in the trials, and translating results of heart failure trials to an 80-year-old with comorbidities I think is really problematic. I would say go slow but stay persistent. MRAs are really important and they're worth the effort. RALS was one of the strongest trials in cardiology. Anyways, I know this might be controversial and the proponents of heart failure disagree with me. Let me know what you think about this less aggressive approach to the most common heart failure patient, which is an older patient with comorbidities. So that's it for this week in cardiology. As always, I'm grateful that you listened, and remember, please, if you like this podcast, take the time to go to the podcast app, give us a rating, write me a review, write a comment if you disagree with something on the heart.org website. I love learning from the comments. Until next week, this is John Mandrola from the heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.